Good afternoon, everyone, again. I would like to thank Dr. Sri Ganesh and Dr. Supriya for giving me this opportunity. So for this case, we have just done only the ಕೆಳಗಡೆ ನೋಡ್ತೀರಾ ಸರ್ ತಲೆ ಅಲ್ಲ ಬರೀ ಕಣ್ಣು ಕರೆಕ್ಟ್ ಆಗಿದ್ದೀರಾ ಲೈಟ್ ನೋಡಿ ಸರ್ so this is one of the issues you can have in these kind of cataracts, where the patients are unable to follow the light, but nothing to worry. No, main port. So if you look at my main ports, usually I do extremely, extremely limble and a very short one, so as to induce as less astigmatism as blue, epitrate also, adrenaline. So even though it's a femtorex is done, it's always good to stain once because you have to make sure that it is completed at all points. Light note here, sir. Adrenaline and oculon, please. Not visco, adrenaline, please. And oculon, please. Oculon. Okay. So what is very important, light nodi sir? Light nodi? So light nodi sir? Light? So what light I note beko? Light nodi sir? So what you can do is, even with this cannula also, you can just, if you pull all the edges, so you're good. So you don't need to take your even cystotome and just check. Okay. What is very crucial is to look at the gutter. Now in these cases, always reduce the visco in the chamber and then do a very gentle dissection. And light notice, sir? So the angle keeps changing. If he, like Dr. Ron was saying, you can see that raise here, and then you can see the second wave. Now look at the same area now. Look at the light, sir. Light notice, sir? Can you see the second wave? That's it. So once you've got the second wave, you're good to go. So then what you can do is you can continue with your Phaco. Visco, regular Visco, HPMC, please. Yeah. So always before you start your Phaco, it's good to fill your chamber completely with viscoelastic and then start. So the system which I'm using here is the Centurion system. This is not the active centric handpiece. So with the active centric handpiece, I usually operate at 22 IOP, but with this little higher, maybe about 32 or so. So once you remove, it's a little harder cataract, you can observe. So that's why I didn't want to do the femto chops, just to showcase how do we handle these cases with very hard nuclear grade. So what is important is make sure that a good amount of the tip is impaled. Once that is done, just a quick chop towards the tip and then sideways. Okay? Again, rotate. Do as small chops as possible. So you've got a good hold towards the tip and sideways. And take the dialer deeper and deeper and make sure it's 100% separation. The same thing we need to repeat. Got a good hold towards the tip. See, it's very important not to move your phaco probe down when you're chopping. This is where the chopping usually doesn't happen. So once you've got a good hold, right? See, I'm almost either in the same plane or I lift it up also is okay, but never push it down. If you push it down, your plane of chopping changes, so you won't get a good chop. It's a little fibrotic also, but we have a good, so I'm just eating the central part now. Got a good hold. Just have to repeat the same. The key thing is you have to do it slow. It really tests your patience, because these kind of cataracts, when you lose your patience, that's when things go wrong. So I finished chopping all my pieces. Autocoat, please. So any kind of just autocoat. Okay, doesn't matter. So any kind of viscoelastic, once you finish your chopping, just fill the chamber. Phaco, please. So what I normally do is I take out my second hand piece and start doing the Phaco in one hand itself. So what is important is whenever you press step 3, right? See the level. I'm at the level of the iris. Okay. I don't move my Phaco probe so that my corneas are nice and clear. And look at the ease at which it's able to, eat even in these hard cataracts. It's very, very simple. So the key is to do as small pieces as possible. Light nodi, sir? So it's important to make sure the eye is facing up at all points. Because if the patient is looking up or some other direction, what happens is the plane at which you're phacoing is different. If you look at the stability, it's completely rock solid.
You don't use any second hands in this part?
Sorry?
You don't use any second part in
No.
second hand?
You mean the second hand piece?
Yes.
Yeah, so I don't use it here. So why I don't use it here is, you see this, from the side port, there's no leaks. So it creates much better fluidics. And then what happens is the pieces comes to the phaco tip more easily and the chattering around is lesser. So that's why I never, onchur closer, it's very far away, the tube speaks. So I usually use a bimanual one. So you can just fill the chamber through the main port. Once that is done, okay. So, hey, aspiration cannula. Aspiration cannula. Sorry, yes, ma'am.
Yeah, you have used
That is the
HP.
aspiration cannula. It's irrigation cannula. Sorry.
You have
So,
used only the HPMC.
yeah, HPMC, ma'am. Yeah.
Though it was a hard cataract. Do you use
So,
only HPMC?
so you, for chopping the pieces, you don't need to do anything. So only for after you, if you observed, ma'am, after I have finished chopping, what I have done is light notice, sir. So what I've done is IUP, Anu, 70, light A note vehicle. Light A note vehicle. Sorry, there's a lot of visco on the cannula, so it's becoming very slippery. So after I finish chopping, then what I do is I add visco. That's when you can either use, sir, kan muchbardu hage. Yes, very nice. Hage light note vehicle, sir. So it's important, if you hold the capsule like that, instantly you have to remove, and then you can polish your anterior capsule. See? So usually it's a little more floppy once you remove the piece in these kind of brown cataracts. It's a little more floppier. So what you can do is either you can just polish a little bit of this. See, you can make out, right? It easily comes to the bag. So in these kind of cases, you have to be extremely, extremely careful. IOL, please. So what I do is I do it under irrigation itself. So my assistant, rotate. My assistant rotates it for me. And this is all under irrigation itself. So it's a very controlled way of delivering. So once that is done, what I do is whisk on the cornea, please.
Which IOLs do you use now?
Yes, sir. Yes, sir. I'll come to that, sir. So if you see, don't push the IOL directly down. Try to hold the edge of it. Okay? Push it towards the center. So that what happens, you don't push on the iris and the patient doesn't have pain, and you don't, disturb the iris too much, and it leads to more prostaglandin release if you disturb the iris too much. So the lens which I'm using is the Clarion Panoptics. It's a fantastic lens. Actually, if the eye is very pristine, let's say if they don't have too much high order aberrations, retina is perfect, everything, cornea is perfect, everything is good, There's nothing better quality of vision when you do bilateral panoptics and you hit the target, patients are super, super happy. I think that is something that is really, really fantastic. So once you do this, what you have to do is just make sure you wash the visco from the endothelium also, and then you're good to go. I think that's about it. So don't, thank you. Thank you. So I didn't want to do the femto chops because not everyone has a femto cataract with them. But what I also wanted to show is a femtorexis, even in these kind of hard cataract, when you're trying to bring the pieces out, nothing happens. They're really good, very strong. They shouldn't be. And look at the centration. It is super, super beautifully centered, very useful in these kind of premium lenses where, you know, the centration and the stability of the IOL is very, very important. Now, what is important is once you finish, right, this is something that all of us should do. We remove the speculum and then we just don't see the eye. It's very important to look at the eye pressure once you release it and then only go. Because a lot of times we remove the speculum, the IOP reduces, and because the IOP reduces the next day, either the patient sometimes has a higher risk of infection, or sometimes because of the hypotony, you can have a more edematous cornea also. So it's important to always remove the speculum, check the IOP, and see how the eye is taut or not, and then only close the eye. And I mean, thank you so much. I hope it was the surgery was visible, and I'm happy to hear any questions from the hall.
The surgery was beautiful and looked very easy in your hands.
Thank you, sir. Thank you so much. But the key is, I think, see, the whole point is there are two things in handling these kind of hard cataracts. First is when you do chop, if you observe the chop when I was doing, I didn't go too deep. The first, when the chop when I do, you don't need to go deep. You chop it, when you separate it, while you're separating, you can go deep. So that's one thing which is very important. The second thing is small pieces. Always target small pieces. It becomes so much more easier for your phaco machine to eat. Suddenly it starts behaving like as if it is NS2 grade. So it's important to remember these 2 points in handling these kind of cases.
Do you refill viscoelastic each sometimes in these cases?
Which viscoelastic, sir? Sorry?
Yes, do you refill viscoelastic inside of the anterior chamber?
Yes, sir. So the important is, let's say if the grade is on the higher side, what we can do is, after you finish your chopping, right, just before you start your phaco emulsification, just fill the chamber once again. Because see, when you're actually doing the chopping, whatever phaco energy you're delivering, it's all into the lens. So actually that won't anyway damage the endothelium. It is the one what you use to do your quadrant removal. That is where actually the damage happens. So it's important to fill up and then do your quadrant removal. And automatically, you know, your corneas are nice and clear the next day. All right, I think thank you so much for everyone. Again, thank you, sir, for giving me this opportunity. Thank you everyone.